Hey, future RNs, let's talk about a big one, ventricular tachycardia, VTach. It is, without a doubt, one of the most dangerous and, you guessed it, most tested rhythms on the NCLEX. You'll see it pop up in those cardiac arrest, priority, and emergency questions. So today, we are going to break it all down. The ECG features, the causes, the signs, and most importantly, what to do first. We'll cover treatment and monitoring too, so you can walk into your exam and answer these questions with total confidence. Welcome to ClearPath NCLEX. This is your spot for high-yield content that's all about helping you pass on that very first try. So if I asked you, what's one of the scariest, most dangerous rhythms you're going to face on the NCLEX, what would you say? Well, if ventricular tachycardia came to mind, you are spot on. Seriously, mastering this rhythm is absolutely critical, not just for your exam, but for being a safe and super effective nurse out on the floor. All right, you ready? Let's dive in. Okay, so first things first. What even is ventricular tachycardia? The easiest way to think about it is like a dangerous electrical short circuit happening way down in the heart's lower chambers. So VTach is this incredibly fast heart rhythm, but the key is where it starts, in the ventricles, not where it's supposed to. We're talking heart rates of over 100, but they can get crazy high, like up to 250 beats per minute. Now, here's the real problem, the reason this is so bad. When the ventricles are firing off that fast, they just don't have enough time to fill up with blood between beats. It's like trying to fill a bucket with a fire hose that's whipping around wildly. And if the heart can't fill, it can't pump. That means very little blood and oxygen are getting out to the body and especially to the brain. And that is why VTach is such a huge deal. So what kicks off this electrical chaos in the first place? Well, it's usually a heart that's already stressed out or damaged. Think about things like a heart attack, an MI, or heart failure. That damage can create scar tissue, which totally messes up the normal electrical flow. And what are some other huge NCLEX triggers you've got to know? For sure, electrolyte imbalances. You have to keep an eye on low potassium and low magnesium. And then, of course, drug toxicities. This could be a prescription med like digoxin or even illicit drugs like cocaine or meth. Okay, so now you know what it is and what causes it. How do you spot it? What does it actually look like on that ECG monitor? Honestly, being able to recognize this rhythm is your first, most critical step. So let's break down exactly what you're looking for. There are 4 key things you need to burn into your brain for VTach. These are its signature moves. First, the rate. It's fast, right? Usually somewhere between 120 and 250. Second, the QRS complex. This is the big one. It's going to be wide and look really bizarre, definitely wider than 0.12 seconds. Third, P waves. You're not going to see any normal ones. They're either totally absent or just not connected to the QRS at all. And fourth, the rhythm. It's typically very regular, just a steady, scary fast beat. Let's say it one more time together. Fast rate, wide QRS, no P waves, and a regular rhythm. Got it? Okay, you're looking at the monitor. You've identified those 4 signs. You know it's VTach. Now what? Well, right now you have to answer the single most important question. This one question changes everything you do next. And that question is, does my patient have a pulse? And this is so important because VTach can show up in 2 totally different ways. On one hand, you could have a patient with a pulse. They're conscious, but they are not doing well. They might feel palpitations, be dizzy, short of breath, maybe have some chest pain. Their blood pressure is probably low. This is absolutely an urgent situation. But on the other hand, you could have pulseless VTach. And in that case, your patient is unconscious, they're not breathing, they have no pulse. This isn't just an emergency, my friends. This is cardiac arrest. All right, let's tackle the most critical scenario first. Your patient is in pulseless VTach. This is a code blue situation. Every single second counts, and your actions have to be immediate and precise to save this person's life. When it comes to pulseless VTach, you need to think simple and fast. First things first, you see that rhythm on the monitor, you check for a pulse, there's nothing there. You immediately start high-quality CPR. Push hard, push fast. At the exact same time, you are yelling for help, activating that code. And as soon as that defibrillator cart rolls up, you're going to defibrillate. This is an unsynchronized shock. We're not trying to time it with anything. We're just trying to stop that chaotic rhythm dead in its tracks. It's the most important thing you can do. Just remember this little phrase. VTach with no pulse gets the DEFIB, of course. Okay, let's switch gears completely. What if you walk in, you see VTach on the monitor, but your patient does have a pulse? They're talking to you, but they're unstable. This is still a massive emergency, but your game plan is going to be totally different. So, for a patient with a pulse, your very first move is to call for a rapid response. But you do not leave your patient. Stay right there with them. Your job is to stabilize them. Get some oxygen on them, make sure you have good IV access, and get ready to give some antiarrhythmic beds, usually amiodarone. Now, if their blood pressure starts to tank and they're getting more and more unstable, you have to be ready for synchronized cardioversion. This is still a shock, but it's a lower energy one, and it's timed perfectly with their QRS complex. The goal is to sort of reboot the heart back into a normal rhythm. And this is the key difference you have to know. If there's a pulse, you cardiovert. If there's no pulse, you defibrillate. So just to recap the treatments really quickly. For Pulseless VTach, your go-to tools are defibrillation and meds like epinephrine. For VTach with a pulse, we start with medications like amiodarone. And if that's not cutting it or the patient gets worse, we move to synchronized cardioversion. And then, thinking long-term, these patients might eventually need a procedure like a catheter ablation or get an implantable defibrillator, an ICD, to prevent it from happening again. All right. You have absorbed all the essentials. You know what it is, how to spot it, and what to do. Now, let's lock it all in. We're going to run through a few NCLEX-style questions to really make sure this knowledge sticks. Okay, first question. Your ECG shows a regular rhythm, a rate of 180, wide QRS complexes, and no visible P waves. What's the rhythm? Think about it. That is textbook ventricular tachycardia. You hit all 4 of those classic signs. Perfect. All right, next one. You find a patient, they're unresponsive, they're pulseless, and the monitor is screaming VTach. What is your immediate priority action? Your absolute first move? Start high-quality CPR. You have to get that blood moving while you call for help and wait for that defibrillator. Okay, question number 3. You have a patient who's in stable VTach, they have a pulse, and they're prescribed an antiarrhythmic. Which medication are you going to anticipate giving first? That's right, it's amiodarone. That is the go-to first-line drug for stable VTach. Okay, here comes a fun one. A select all that apply. A nurse is caring for a client who develops VTach. Which of the following are common causes? A, an MI. B, hypokalemia. C, atrial fibrillation. D, digoxin toxicity. Or E, hypertension. Go ahead and pick all the ones that apply. Okay, you ready? The correct answers are A, B, and D. A heart attack, low potassium, and digoxin toxicity are all huge risk factors for VTach. All right, next question. Your patient is in VTach with a pulse, but suddenly their BP plummets to 78/40. They're becoming unstable. What's the nurse's priority action? A, give a fluid bolus. B, prepare for synchronized cardioversion. C, give amiodarone IV push. Or D, just keep monitoring. The answer here is B, prepare for synchronized cardioversion. When a patient with a pulse becomes this unstable, medication is just too slow. They need that electrical reset, and they need it now. Last practice question, and this one is all about patient teaching. What is the most important thing to teach a patient who is being discharged after having an episode of VTach? A, how to count their own pulse. B, signs and symptoms to report immediately. C, the importance of a low-sodium diet. Or D, the need for daily exercise. The number one priority here is B. They absolutely must know the signs and symptoms to report immediately, things like palpitations, dizziness, or fainting. Why? Because that could mean the VTach is back, and that's a medical emergency. Okay, let's wrap this all up with the ultimate NCLEX cheat sheet for VTach. When you see it, what are you looking for? A wide QRS, a super fast rate, and no P waves. What causes it? Think MI, heart failure, low electrolytes, or digoxin toxicity. Now for the action plan. Is your patient pulseless? It's CPR and defibrillate. Do they have a pulse? Your go-tos are amiodarone or cardiovert. Simple as that. Look, VTach is definitely a high-stakes rhythm on the NCLEX, but mastering that one key difference, pulseless versus stable, is how you're going to absolutely crush these questions. You can do this. Thanks so much for hanging out with me here at ClearPath NCLEX. If this explainer helped you, do me a favor and hit that like button and subscribe for more high-yield NCLEX content. And don't forget to ring that notification bell so you never miss the next tip. Before you go, drop a comment below and tell me, which VTach sign or action do you always remember? I love reading them all. You are doing an amazing job. Keep up the hard work, keep studying,